My name is Lauren Cohee. I'm from the University of Maryland School of Medicine, and I'm going to talk with you about Project 2, which is the Malawi ICEMR project focused on characterizing the transmission reservoir. As Don and Charles both highlighted, in our first ICEMR, we noted that the parasite prevalence peaks in school-age children, which you see here in the light gray bars. And as Charles discussed, this has both biological and behavioral underpinnings. A second finding that highlighted our interest in, or piqued our interest in school-age children, was that the prevalence of gametocytes, here in the darker shaded bars, also peaks in school-age children. And this is not driven only by the parasite peak in this age group, but also a higher proportion of infections contain gametocytes in this age group. And that's shown here on this with the solid line. These findings led us to undertake some simulation modeling to evaluate the contribution of different subpopulations to mosquito transmission. Taking into consideration just our gametocyte findings, we showed that about 50% of mosquito infections likely come from the school-age population. When we also include differential bed net use, implying that people are more available to vectors for biting, the contribution of school-age children increases further. If we also include differential biting by body surface area, the contribution of school-age children goes up to about 60% of all mosquito infections. These findings led us to focus on further quantifying and characterizing the transmission reservoir within Malawi. Our ICEMR 2 studies aim to do this by addressing three specific questions. One is, what are the characteristics of infections most likely to be transmitted? And this we are undertaking using the gold standard assay, being membrane feeding studies. The second question is, what is the population distribution of these infections that are contributing to transmission? And thirdly, we aim to quantify risk of vector exposure by matching human and mosquito blood meals. All of these studies are being addressed in the context of two cohort studies. As Charles described, they are taking place in two sites in southern Malawi, one Namanolo and the other in Taja. The map I'm showing you here on the right is our Taja site. For our gametocyte entomology cohort, which took place from 2019 to 2020, as Charles mentioned, ending slightly early due to the COVID pandemic, we aim to enroll all members of individual households, and households were selected from ecogeographic quadrants in the health center catchment area. We sampled one index house and then between 4 and 6 additional households immediately surrounding it to include 16 household clusters per site. And we followed all participants in this cohort with active case detection monthly. And this active case detection included an interview about malaria risk factors and current symptom status. We collected a finger prick blood sample at each visit and stored blood on filter paper for quantification of total parasites using qPCR against the 18S target. And then we preserved whole blood to detect sex-specific gametocyte RNA transcripts. As Charles mentioned, we also conducted passive case detection to document active malaria cases and treatment seeking. Nested within this cohort, we also conducted vector sampling, aiming to capture indoor resting blood-fed Anopheles mosquitoes, which we did in a subset of houses using pyrethrum spray catches and CDC light traps. Our second cohort study, which is in a subset of houses in this Taja site, is our membrane feeding cohort. It's ongoing currently, and again in this study, we aim to enroll all individuals in the household. In this, we're sampling participants every 2 weeks and screening for infection by microscopy and qPCR. And of participants with infections, we're conducting membrane feeding assays. I'll now share with you preliminary results from our gametocyte and entomology cohorts. This work, I'll talk to you about our gametocyte detection, and this work has been led by Natalie Horstman, who is actually an MPH student who conducted her capstone research from Hopkins, but with us at University of Maryland. Rob McCann and Jimmy Beretta, who's a Malawian graduate student who's supported by a D43 training grant and whose dissertation work will be conducted within our ICEMR study. First, I'll divide our cohort based on their symptom status. And I say asymptomatic here in quotes because I'm dividing us just by our active case detection visits, mainly because while this group may have had symptoms, they were not actively seeking treatment, and thus case management will not reach this population. So I'm going to term them asymptomatic in quotes. And among those active case detection visits, of which we had 7,500 during the course of the cohort, with a range between 1 and 11 visits per individual participant. This was an open enrollment cohort, so follow-up time by participants varies. We'll compare that group to the passive case detection, so individuals who had symptoms and presented to the clinic for evaluation. Over the course of the study, we had over 1,200 of those visits, with between some participants experiencing no clinical illness and some participants visiting the health center up to 20 times. As anticipated, parasite prevalence overall was higher in the group seeking treatment. However, when we look at gametocyte carriage among these populations, the proportion of infections that contain gametocytes was higher in the asexual population. Furthermore, the geometric mean gametocyte density of the gametocyte containing infections was higher in the asymptomatic group. Gametocyte sex ratio was female biased in both groups, but less so in the active case detection visits. If we divide our population instead by age group, we see, as anticipated based on our ICEMR 1 findings, that total parasite prevalence again peaked in the school age group. Among those infections, a higher proportion of infections contained gametocytes again in the school age group. Gametocyte density decreased with age, and the sex ratio was again, as anticipated, female biased, but less so among the older adults. Our blood meal matching studies have led us to the conclusion that vector feeding is non-random. This work is being led and has been led by newly mentored Dr. Rex Mbewe, who is a Malawian who recently obtained his PhD from Michigan State University, again with support from the D43 Fogarty training grant. In his work, we collected 424 human blood-fed Anopheles mosquitoes, and 250 people reported sleeping in the households during the times of the mosquito sampling. Full human genotypes were obtained from 370 mosquito blood meals, resulting in an overall genotyping success of 87%. Within those 370 mosquitoes, we detected only 46 unique human genotypes, and individual humans contributed to between 1 and 49 mosquito blood meals, highlighting again that vector feeding is non-random. 60% of these blood meals came from males, who made up only 45% of the at-risk population. We were able to look at unique human genotypes and sex as an outcome in all of our successful genotyped blood meals. However, we're only able to evaluate age in those that matched participants within our cohort. And among those matched blood meals, again, we see that school-age children are overrepresented. As I mentioned, our mosquito feeding, our membrane feeding cohort is ongoing. We've enrolled 146 participants in 28 households in 4 of our original household clusters. And this work is being led by Dr. Jesse Gupeo-Yumsi, who's a postdoctoral fellow at the Malaria Alert Institute, and also supported by the D43 training grant, and Joyce Nirango. Overall, our findings suggest that school-age children and asymptomatic infections contribute disproportionately to gametocyte carriage, We will be able to more fully quantify their contribution to transmission once we have the full results from our membrane feeding cohort and can incorporate our vector matching into statistical analyses, incorporating all aspects of the transmission cycle. As our next steps, we will continue our membrane feeding cohort. We are conducting further laboratory analysis, continuing our gametocyte sex ratio assays. Jimmy Verretta will lead work on gametocyte commitment, and we're also evaluating transmission reducing immunity. And as I mentioned, we'll be conducting much more comprehensive and detailed statistical analyses. Overall, the policy implications of our work is that we, as Charles also highlighted, need to increase access and use of existing control interventions by the transmission reservoir, in addition to, as Charles highlighted, having more effective conventional tools, more effective nets. Peer-to-peer education programs may be an attractive approach to increasing bed net use among school-age children. And for those children who are symptomatic, increasing kid-friendly access to healthcare clinics. Furthermore, we need to identify new strategies to reduce the transmission reservoir. An area of interest is chemo prevention, targeting school-age children, both for the health benefits and potential transmission reduction capacity, as well as focusing on how to further develop and then target transmission reducing interventions like vaccines or monoclonal antibodies. Thank you.